Uh, Good morning, good afternoon, good evening, everyone. At the outset, I thank the organizers of the MENA Stroke Conference for inviting me on behalf of World Stroke Organization to give this talk on acute stroke management. And what I'm going to cover is, besides thrombolysis and endovascular treatment, I will cover the acute management of stroke. So this slide shows the pillars of stroke recovery. And we can see here the base is the stroke unit care. In the stroke unit, you deliver thrombolysis, endovascular treatment, and control some of the factors that worsen the outcome of stroke, and also take care of the nutrition and also the treatment according to the stroke subtype. This slide shows the table in the left-hand side is the interventions that are available for stroke, and it is extrapolated to 5 million population of having 10,000 strokes a year. Basically, it tells the population impact of these interventions in terms of impact in terms of extra-independent survivors per year. The last column you can see here, for each intervention, this is the number of extra-independent survivors. Among all the intervention, you can see the stroke unit care as the highest population benefit. If you combine some of the activities that happen in the stroke unit, like starting aspirin, thrombolysis, thrombectomy, and rapid secondary prevention, it would cross close to 600 or 700. So stroke unit care has a major population impact. So what is stroke unit care? And stroke unit is defined as an area within a hospital where stroke patients are managed by a coordinated multidisciplinary team specializing in stroke management. So what happens? Stroke patients, when they are managed in stroke unit, that leads to improved outcomes. Why stroke units are effective? Number one is there is a geographical concentration of stroke expertise, and there's a team approach. And there are many factors that can lead to worsening in outcome of stroke patients. Those factors are addressed, particularly, for example, swallow assessment, that can prevent pneumonia and the other complications, and early implementation of secondary prevention strategies, early rehabilitation. And the most important one is the motivation of the entire team and involving the patients and families. What is the evidence that we have? This is the latest Cochrane review for the organized inpatient or stroke unit care from more than 40, almost close to 50 trials in different types of stroke unit. And patients who are managed in the stroke unit are more likely to be alive, living at home, and independent at 1 year after the stroke. And irrespective of the stroke subtype, this benefit is seen, and the results appear to be very significant in stroke units based in a dedicated stroke ward. So what are the things that happen? What are the interventions that happen in the stroke unit? Number one, management of blood pressure. In a stroke patient, the BP has to be reduced if they have hypertensive encephalopathy, coexisting acute renal failure, acute pulmonary edema, and myocardial infarction. Otherwise, why there is a increase in blood pressure? Number one, it could be a stress of stroke. Sometimes patient is unconscious, not able to communicate. There's full bladder, and there'll be pain, and that leads to sympathetic surge and pre-existing hypertension. It could be a physiological response to hypoxia and a physiological response to increase in ICP. And stroke patients can have hypertension, and if they are volume depleted, aortic dissection, myocardial ischemia, or cardiac arrhythmias. So what are the benefits of lowering blood pressure? Yes, you can probably prevent expansion of brain edema, improve the reperfusion, and we can prevent worsening of hemorrhagic transformation and further vascular damage. And increasing blood pressure would be beneficial in a patient with critical stenosis, and also to maintain cerebral perfusion pressure in these patients. So the target blood pressure in acute non-reperfused ischemic stroke, it is 220 by 120. Acute reperfused ischemic strokes, 180, 105. And acute intracranial hemorrhage, we have some evidence that you can aggressively reduce within 6 hours and maintain below 140 for the next 7 days. And this is a trial, for ENOS trial, where they randomized ischemic stroke patient and hemorrhagic stroke patient. If the BP was more than 142, BP was between 140 to 220, the first 48 hours to GTN patch was a no GTN patch. And if they were on BP medications earlier, to continue BP medication or stop BP medication. This trial recruited 4,011 patients, and they did not find any significant difference in terms of outcome, whether patients were put on GTN patch versus patients who were continued medications or stopped antihypertensive medication. In ICH, there's a landmark trial, Interact 2 trial that I mentioned. In the acute phase, you can reduce the blood pressure to around 140 and maintain for the next 7 days. In primary outcome, there was no difference. However, in the secondary outcome, there was improvement in quality of life. And another important factor is avoiding the BP variability in the first 7 days. If you keep it stable around 140, that also leads to good outcome. So moving on from blood pressure to simple nurse-based interventions. It is called FES, that is fever, sugar, and swallow. So hyperthermia has a poor outcome in terms of stroke. And in this FES protocol, this is a protocol adapted in a QUAST trial, which I'll be discussing. And any temperature more than 100.4 degree Fahrenheit, you use paracetamol and monitor the temperature and keep below 99.5 Fahrenheit. And the second one is a blood glucose. So 10 millimoles. So that is it's about 180 milligrams. So this is a protocol for managing sugar, which can be managed by the nurses if they use this protocol. And you need to basically keep the target between 140 to 180 and avoid hypoglycemia. And if the blood sugar is high, use a glucose insulin infusion and use this protocol to control blood sugar, both in diabetic patients and non-diabetic patients. Another important thing is the swallowing screen. You can use different swallowing screens, but it has to be done as soon as they are admitted based on your availability, and then decide whether to feed these patients or not. This prevents aspiration pneumonia. This care bundle was tried in a cluster randomized trial in 19 stroke units in Australia called QUAST trial. What did they find? The intervention patients were significantly less likely to be dead or dependent at 90 days as compared to the control group. There was a reduction in mean temperature, there was a reduction in blood glucose, and the swallowing screening improved when they used this care bundle. And there was some reduction in length of hospital stay in this group of patients. This is a simple nurse-driven intervention which can be implemented in stroke unit. What is the best head position in acute stroke? So very often we have seen patients, when they come in, they are okay, and then you shift them to the scanner and make them to sit and lift them up, and changing that position can lead to some worsening of stroke, particularly when they have a large artery occlusion. Many of us have seen. So in this situation, what is the best head position? This was tested in the head post trial, which was a cluster randomized crossover trial done in 11,000 patients. 85% were ischemic stroke patients. Basically, within 24 hours, Patients were either randomized to for first in the hospitals. The first treatment modality is keep the head end flat or keep the head end up to 30 degree. And the primary outcome was improvement using modified ranking scale. There was no significant difference between these two groups. It's a large trial and a very pragmatic trial. And so you can use any position and see the convenience of the patient and whether they have a large vessel occlusion or not. Other complications, the pneumonia, you can prevent pneumonia by keeping them semi-upright position, frequent suctioning and chest physiotherapy. Formal swallow assessment should be done before we feed them, and this can reduce pneumonia. Prevention of DVT and pulmonary embolism, these are standard protocols. Either you use unfractionated heparin or low molecular weight heparin. Intermittent pneumatic compression is the treatment of choice. TED stocking is ineffective. Second, prevention of ischemic stroke. As within 48 hours, you need to put them on aspirin. The other drugs are clopidogrel and aspirin diphenol combination. If the lipids are deranged, you can put them on atorvastatin, 80 milligram per day, anticoagulation in patients with atrial fibrillation, and control all the other risk factors. Rehabilitation in acute stroke, it is very important, and how early we can start. This was tested in our trial where within 24 hours, the patients were randomized to intensive harm, that is the high intensity mobility training about 8 times daily, 20-minute session for about 14 days or till they were discharged from the hospital versus usual care. This particular trial, what they showed was that very early, very high intensity mobility training within 24 hours was harmful and it should not be done. And then our dose, which is an ongoing trial, is looking at after 24 hours, so what intensity, how frequent we can mobilize them, and that will be answered through our dose. Another important thing in rehabilitation is involvement of caregiver, training of caregiver, which was tested in this trial in India. Called ATTEND trial. About 14 centers in our country participated. 1,250 patients were randomized to either intervention arm or control arm. In the intervention arm, the physiotherapist trained the caregivers to deliver rehabilitation in their homes. And this trial was neutral, but many lessons that we have learned from this trial can be implemented as a home care program for these patients. Early discharge planning is very, very important. While they are in the hospital, we need to involve the multidisciplinary team and come up with a plan at the time of discharge, clear-cut goals at all levels for the nurses, for the rehab experts, and offer them community support and for up to 3 months. And this has shown benefit from a Cochrane analysis where appropriately resourced ESG services with coordinated multidisciplinary team input can reduce disability and length of hospital stay in a select group of patients, probably mild to moderate strokes. So how can we develop stroke care services? And there are, particularly in low and middle income countries, there are several models available because neurologists are not there in adequate numbers in LMICs. So one of the models that we tested in a remote hospital in Northeast India, in a place called Tejpur, it's a secondary level hospital, we reorganized the existing infrastructure and add dedicated beds for the stroke unit and train the nurses, staffs, and they had an in-house CT scanner. And we collected, before we implemented the stroke unit, baseline data, and after implementation of stroke unit. And we can see here there is a gross reduction in the complications and all the key performance indicators in terms of swallowing assessment, mobility assessment, education, multidisciplinary approach, initiation of anticoagulant drugs, antiplatelet drugs, initiation of antihypertensive drugs. All these key performance indicators improved in the post-stroke unit care. The length of hospital stay also improved. However, the outcome was not different between both the groups, but at least we are able to demonstrate the improvement in key performance indicators. So this slide summarizes the different models of care available in LMICs. The typical one is a multidisciplinary care where the stroke neurologist and the multidisciplinary team takes care of the patient. It is where all the facilities are available. Specialist-led care is a neurologist, but not interested in stroke. The stroke unit may be present or not. Then there's a physician-based model, which I just talked about. And then the hub and spoke model using government healthcare infrastructure, where the primary health centers, secondary health centers can be attached to the tertiary government hospitals in a hub and spoke model. The last one is the task sharing. The frontline health workers can be trained in the villages to identify these stroke patients and create a network involving hub and spoke with the government hospitals. So these are the models that are available in low and middle income countries. Lastly, how to organize a stroke unit in resource limited setting. You need to identify a dedicated area, start with 6 beds, have some monitors and infusion pumps, train the nurses, the doctors, create a team, and have at least a modified multidisciplinary team with the physios at least. And you need to have protocols for all this. So the multidisciplinary team can meet separately, or they can join the ward round and combine the meeting with the ward round, so that you can, because everyone is busy, they are overloaded with patient, involve the family, and have a clear-cut discharge plan, as I mentioned earlier. The number of staff depends upon the availability locally and also the volume of stroke patient that you see in the centers. Who will run the stroke unit? Anyone who's a champion who wants to drive the stroke care should be running the stroke unit. And more information you can see from the World Stroke Organization, World Stroke Academy, Essential Stroke Services, which has all the details of how to start a stroke unit. In conclusion, stroke unit care is crucial in the acute management of stroke. Simple nurse-led interventions can improve outcome. A coordinated multidisciplinary team is essential. And in low and middle income countries, models of stroke care are available, and people can use these type of models and organize stroke care in their own countries. And I sincerely thank my team, Christian Medical College Ludhiana Comprehensive Stroke Care Program. Thank you.